Thanks so much, Jonathan, for setting the stage in terms of understanding the contribution of heart rate to heart failure. Not only it's associated, but it may actually fundamental to some of the adverse consequences. And also, I think putting together this bench to bedside type of continuum. What I like to do is actually follow up on Jonathan's discussion and actually look at some of the evidence in terms of treatment effects using biomarkers as well as potential outcome, and in terms of some of the evidence-based therapies that we have. And I'd like to now take advantage of the audience response system to get your advice on this question. So we do know that there are markers such as pro-BNP or natriuretic peptides, and these are excellent predictors of outcome for patients with heart failure. And the question is, do newer treatment for heart failure with reduced ejection fraction, such as ivabradine or sacubitril/valsartan, impact at all in terms of markers such as pro-BNP in our patients? And so the question, so the options are the following. A is reduce the marker somewhat, but rather slowly. That is, that it takes a little bit of time to actually show a reduction in marker. B, you can actually reduce this very significantly, say more than 30% from baseline, but do this relatively slowly. And C is reduce the marker somewhat, but do so quite rapidly within 1 month, for example, of exposure to the medication. Versus D, that's reduce the marker significantly, more than 30%, and can do so rapidly in less than 1 month, or that the effect on markers is inconsistent. And I'll ask you to vote now. Oh my God, you folks have already answered the questions already. This is a very responsive audience. Okay, so I think that the trend is actually quite clear. Hopefully this is a little different from our upcoming provincial election, but nevertheless, the most favored answer is reduce NT-proBNP very significantly, more than 30%, but do so relatively slowly over time. And I think this is a very reasonable consideration. But let's take a look at the data, because the answer turns out to be the next one that's most popular. Answer D is actually reduce these markers quite significantly and do so very rapidly. So it's kind of an interesting insight as to how these agents might work. So we do know that in the setting of heart failure, it's actually complex interplay not only of the cardiac challenges in terms of the injury and malfunction as Jonathan has elegantly illustrated, but it also impacts on other systems, and that includes the increase in peripheral resistance, and that is a result of circulating neurohormones, but as well as an impact in terms of the cardiorenal response with decrease in renal function, as very much appreciated clinically. And some of this also result from various mediators actually released from the injured myocardium, and that's actually underperfused and may actually be metabolic challenged as well. And this is associated with increased heart rate, as we have already observed, and also other systems that's activated, including immune inflammatory system that's contributing to the remodeling process. And therefore, trying to address this will actually require a number of strategies. But the fact that the myocardium itself actually is under stress, and this actually sets up a vicious cycle. So you can see that if you actually look at a patient who's just being admitted to a hospital, and that the mortality during follow-up is very much accelerated after that hospitalization because of this decompensation. And that each hospitalization, in fact, further aggravates the mortality. And you can see that this is a vicious cycle, so the moment the patient decompensates, the entire system is activated, and injury begets injury. And that this risk is particularly magnified during that first period after the patient's undergoing decompensation. The patient who's recently discharged from hospital, for example, we know they are at a very high risk in terms of mortality and rehospitalization. And this is a challenge not only to the patient, but also to the health system. And that during that critical first month, for example, is where many of these events will tend to recur and magnify and get accelerated in terms of the patient's adverse natural history. And some of these can be reflected, in fact, in many of the markers or molecules that's actually released in the setting of heart failure. And these can become biomarkers that we measure in the serum, for example, as an indicator of patient's underlying condition, the pathophysiology of the process, and also in terms of prognosis. Of course, the one that we're most familiar with and the most commonly measured are the natriuretic peptides, and we'll talk about NT-proBNP as an example, as well as now we know that with the high-sensitive troponin measurements available, that this is an independent predictor of outcome. And this is in addition to other markers such as ST2, galactose-3, and the markers of renal dysfunction. And the question is whether these markers can give us any indication in terms of patients' response to treatment and whether their outcome is actually altered. So certainly we know that the proBNP at the time of discharge is one of the best predictors of outcome for patients admitted to a hospital with heart failure. But their change in terms of the proBNP levels is in fact very important in differentiating patients' outcomes. So you can see that if the patient's BNP during that hospital stay decreased more than 30%, as indicated in the green dots, the patient has actually a much better outcome than, say, patient who actually did not actually have a change in BNP or in fact had a worsening BNP as indicated in blue or red colors. But we're very fortunate in that we are in an era now we have the availability of several evidence-based therapies, particularly for patients with heart failure with reduced ejection fraction, including ACE inhibitor ARB. These are the angiotensin modulators, beta blockers, and a mineralocortical receptor antagonist, which even though has excellent evidence at the present time is actually underused, certainly in Ontario. The utilization of MRA still right now is around 30% for patients discharged with heart failure. And we have the availability of new agents such as sacubitril valsartan or ARNI, which have excellent data in terms of mortality, as well as decreasing heart failure progression, and ivabradine, the heart rate lowering agent that Jonathan has just talked about, with evidence in terms of reducing mortality as well as attenuating heart failure progression. So indeed, when the patient comes into a hospital, we should indeed start the patient on these evidence medications as early as possible. Now, this is a sign, I think, from upcoming midterm elections in the U.S. And if you're in a state like Virginia or Mississippi, you should actually believe in democracy. You should vote early and vote often. Hopefully this doesn't happen on June the 7th here in Ontario, but you should vote anyway. But nevertheless, the principle here is that for the patient who's admitted with heart failure, we should actually start a therapy early and check often in terms of their status. Now, one thing is probably not as well realized is that we tend to actually start patient on these therapies and then methodically, titrate one and then add the other. But what is probably not as well realized as indicated in this network meta-analysis in which taking all the therapeutic trials together with various combinations of agents for patients with heart failure and look at the comparison of individual classes of efficacy. You can see that, in fact, when you look at the agents such as ACE inhibitor ARB or even combination of ACE inhibitor ARB in the green line, that the confidence interval crosses 1, suggesting that, in fact, these agents by themselves overall does not actually impact on mortality as much as we have previously thought. It's only when you actually have beta blockers on board, and particularly in combination of ACE inhibitor beta blocker, that you get increased efficacy. But the the real impact now we have available are some of the more recent combinations, such as ACE inhibitor, beta blocker, and MRA, as indicated in the second line from the top, or with RNA beta blocker and MRA. Really shows that the appropriate combination of evidence-based therapy is where you truly get the home run, and that titrating individual agents over a long period of time actually is not doing patients a service and potentially delay the benefit. And one of the things that we probably don't sort of appreciate as much is the fact that mineralocortical receptor antagonist agents are very effective in terms of reducing mortality, as well as decreasing hospitalization, and that all the MRA trials have stopped early because of overwhelming evidence, and so that they likely will will benefit the patient much more than what we are actually currently using. The other aspect that is also important to realize is that now, in terms of combination therapy, we have a new tool in terms of sacubitril valsartan, which actually is a combination blocker of neprilysin, which one of its functions is actually breaking down natriuretic peptides, which is kind of a nature's answer in terms of setting heart failure to produce vasodilatation, as well as decrease cardiac adverse remodeling. And so the neprilysin inhibitor is able to actually increase the natriuretic peptide levels, apart from other benefits as well, in addition to blockade of the angiotensin receptor. And that this combination has overall 20% reduction in mortality as well as hospitalization. But what is less realized, in fact, this combination decreases sudden death in the patient very significantly, very early on. And you can see the curve separating very early, and in fact, patient accruing benefit within months of exposure. And indeed, one can actually get a readout of the impact biologically on the patient, and keeping in mind that in patient who's exposed to sacubitril valsartan is the NT-proBNP. That's the best readout in terms of the patient's response. And you can see that the patient randomized to the Entresto or sacubitril valsartan, there was very significant drop in NT-proBNP compared to enalapril, and this is measured right at 1 month post-exposure. This shows that the effectiveness is on the myocardium is very, very rapid, and this is in fact translated to outcome such that the patients who are exposed to sacubitril valsartan with reduction of NT-proBNP has very significant reduction in mortality, and this is actually again reemphasizes the importance of proBNP as a marker not only of prognosis but also of stress on the myocardium. What about the evaporating in terms of reducing heart rate? Is this just an associated effect, or in fact this is fundamental to the patient's pathophysiology with heart failure? What is less realized is in fact that when we look at the evaporating's impact on the patients with heart failure, as in the SHIFT trial, particularly those at a heart rate of over 77, as indicated by Health Canada, in that there was actually very, very overwhelming impact on mortality, all-cause mortality reduced by 19%, and certainly death from heart failure reduced by 39%, in addition to the reduction in hospitalization consistently across all the endpoints. And what is particularly impressive is the fact that when you actually look at the patients with heart rate over 77, and that when you actually look at the endpoints of cardiovascular death and hospitalization, that the curves begin to separate within 6 months of randomization, and showing again that the effect and the benefit is very apparent very early on, and this is sustained and magnified over time. And this is the effect on total hospitalization, and keeping in mind that hospitalization and the mortality is a vicious cycle, and that any interruption of hospitalization not only benefits the patient's quality of life, the health system, but also has impact indirectly on mortality as well. And indeed, this effect is seen at the time of first hospitalization was 25% reduction, and this is sustained over time in terms of second and third hospitalization as well. And indeed, one can see that this effect on hospitalization, when one unpack, for example, just the data at the 1 month and 2 months following patients' discharge, that even within 1 month, the cardiovascular hospitalization is reduced by 33% or 1/3. And this is true also for heart failure hospitalization. And this effect is sustained over time, and suggesting fundamentally and biologically, this is a very significant impact. And not surprisingly, then when we actually look at the pro-BNP as a marker, that exposure to ivabradine was able to reduce this by 44% in those patients who are randomized to ivabradine, again suggesting the biological impact on the heart in addition to the patient's outcome. And when one actually look at the different arms of the studies, but this is true in epidemiological studies as well, that the heart rate is a very important calibrator of prognosis, and indeed the greater the degree of heart rate reduction, the better the outcome for the patient. So we can see that indeed we now have the luxury of a number of evidence-based therapies in patients with heart failure with reduced ejection fraction. So therefore, it is imperative for us to get the patient onto these medications that can alter their natural history, but keeping in mind that the monitoring of these patients is important, certainly with MRA and ARNI, monitoring blood pressure, creatinine, potassium is important. And the ivabradine, however, is entirely different, in which it affects only heart rate, none of the other parameters, and therefore makes an excellent complement. So in conclusion, the acute heart failure state of multi-system decompensation markers such as NT-proBNP are excellent in terms of prognosis, and the early initiation of evidence-based therapy are known to improve patient outcomes. And we know that agents such as sacubitril valsartan and ivabradine are associated with important risk reduction, but at the same time also can reduce markers of cardiac stress and prognosis within 1 month of exposure, and that this is an important set of strategies for us to keep in mind to improve the outcome of the patients we all look after. Thank you very much.